Yang, coming from the Taichung Veteran General Hospital. And today we have all the slide, a mixture from the Professor Kondo, Professor Yang, and mine. So because we can shorten our time. Okay, and we are also talking about the PD-1 and PD-1. And PD-1, everyone know maybe on the T cell, PD-1 on the tumor cell, but actually in the world of immunology, it's not so simple. The binding of PD-1 on TC and IC to PD-1 lead to the inhibition of anti-cell T-cell activity. So PD-1 also is placed on T-cell. And PD-1 binding to B7.1 in the lymph node may downgrade T-cell activation. So PD-1 inhibitor, the pharmacy company also advocate they can preserve the immune hemostasis in normal tissue. And also PD-1 inhibitor target PD-1 to restore the anti-tumor T-cell activity. So this is the first question. Which kinds of immune checkpoint inhibitor is better? Because the anti-PD-1 say they can block binding of PD-1 on T cell and PD-L2 on tumor cell. And the pharmacy company from the anti-PD-L1, they say they can block PD-1 on T cell and PD-L1 on immune cell and inhibit B7.1 on dendritic cell with PD-L1 on T cell and preserve prevent the autoimmune reaction. So first, Professor Kondo.
Okay, I have no actually experience in using these IO drug for urothelial cancer, but I have some experience of the RCT, of the renal cell carcinoma. And actually I have experience of both anti-PD-1 and anti-PD-L1 antibody. But for my experience, anti-PD-L1 antibody is less responsive compared to the PD-1 antibody. That's my experience. But, you know, we don't know the result yet, so that's my feeling, according to the RCT.
My point of view is I think both are equal. Both are equal in efficacy result comparing to according to the phase 2 and phase 3 study result. And but I think anti-PD-1 and anti-PD-L1, they did the same pathway on anti-tumor effect. And but I think the anti-PD-L1 might preserve the normal epithelium tissue binding, so we can maybe that can preserve the autoimmune function and also the less adverse events.
So you think the IRA is less in the anti-PD-1? Maybe.
Same, yeah, I agree with him.
Okay. So there's a lot of kinds of immunohistochemistry for the PD-1. You can see Atedo, Pembro, Nivo, Durba, Abe, and they also have different stand for the cell. For example, Atedo only stand for the IC, Pembro, TC and IC, Nivo, TC, Durba, both, Abe, tumor cell only. And why the melon here? Because in the Taiwanese proverb, and Mr. Wang sell the melon, always say the melon is very sweet. 老王卖瓜收瓜甜. Oh. So every pharmacy company say my method is the best. Okay. Okay. So what kinds of cell for PD-L1 expression is more reliable in clinical practice? Professor Kondo.
I think it's the best way to looking at both tumor cell and the immune cell. I think this is the best way. But I think in the clinical trial, the trial using the pembrolizumab, looking at only both things. But I think in the commercially, I think if we're looking at both things, I think it should be better.
I agree with Professor Kondo, because I think if we can check the tumor cell and the immune cell, even the combination, you can see the pembro, durva, and the evolumab, they can scoring the TC and the IC also. So I think it's maybe more beneficial for this kind of testing. Yeah.
Now in my hospital, I use the Pembro, Nibo. Sometimes I use Atezo. So in this PowerPoint, you can see the PD-1 expression is around, for the Pembro, around 30%. It's compatible with our data. Yeah, around 30%.
Yeah, from our clinical trial from the DERBA in our site, you can see the combined positive, the TC and IC, you can see the more than 50.
But I think in our RCC case, I think the patients who show the positive by PD-L1 is less than you see, probably about 20%.
Yeah. Okay, question 3. What about the role of IO in the treatment of UTUC? Professor Yang.
I think that there's no doubt about the standard treatment for the localized prostate UTUC is surgery and the following the adjuvant chemotherapy according to the advanced pathology status. But more concern on the locally advanced UTUC and the following chronic kidney disease after surgery. I think IO play a role for this kind of locally advanced UTUC or CKD stage 2 or 3 after the surgery. I think the IO plays a role in this kind of a patient.
Professor Kondo.
Yeah, actually, I agree with him. Actually, for the UTUC, most of the patients are has a unilateral kidney, so the patient rendered CKD. IO therapy is less influencing to kidney function, according to my experience. Then also the IO therapy for the CKD patient is pretty safe. So I think this has a role of using for the UTUC. Yeah.
So this is the data. So mean EGFR decreased by 24% after surgery, and only 90% after surgery. EGFR maintained the normal. So after the surgery, most of patients will find the decrease of EGFR. And so from the clinical trial, you can see the upper thread, lower thread, the response almost the same. And so for upper thread, is not inferior to the lower thread. Yeah, also this is the clinical trial. Same, so the upper thread is almost the same as the lower thread. Okay, and question 4, 5, maybe together, yeah. Which clinical trial can convince you in the first line setting and second line setting? Professor Kondo.
Actually, we have no experience using these IO drug for the first-line therapy. So, but those 2 studies for the first-line therapy, the phase 2, the single-arm study, and on the in the second-line therapy, the Keynote 045 is only phase 3 randomized clinical trial. So I think that this showed the higher evidence. So I think this is the best show the best evidence.
Yeah, I think the first line. I think the evidence from the TASO and the Pembro, especially if we go to 10 and the Keynote 045, and I think it could convince me to do this kind of first line treatment choice. But for the second line, for the question 5, I think the TASO evidence from the TASO and from the Pembro, especially for the phase 3 Pembro study, they can convince me to do this kind of a second line, especially for cisplatin refractory or failure patient for this kind of IO treatment. But I think you can see from line or Pembro and the TASO, they got better objective response rate, and of course the second line published on the New England Journal of Medicine, Pembro update overall survival by subgroup. You can see even though the PD-L1 combined positive score more than 10, they can get the median overall survival more than 18 months, more than 18 months. Especially for this kind of, for the front line, especially for cisplatin ineligible, you can see the response rate can get more than 20%, and you can get better overall survival from the atezo. You can see the nearly almost 16 months and the pembro almost 12 months. Of course, it is kind of the same picture showing us the same result, especially for the blue bar is pembro and red bar is atezo. It's a higher response rate in pembro and higher overall survival in this kind of all population in atezo. But in PD-L1 overexpression, you can see the higher overall survival benefit in pembro. Yeah.
Okay, so both of you agree to check the PD-L1 for the second line and first line? Okay, so.
Yeah, but in Japan, we are not available. We are not
first
allowed
line,
to
yeah,
use
yeah, I know.
PD-L1 testing
Okay.
for right currently.
Okay, so that's question 6. Yeah, Professor Yang.
I think for the first line, I do believe the PD-L1 testing is required for this kind of first line treatment because from the FDA, from the EMA, or current evidence from the phase 3 study, you can see the first line treatment choice maybe get more beneficial to select the treatment choice. But for the second line, obvious for me, I think we don't have a more treatment choice from the second line or later line. So from the treatment selection, from the outcome prediction, you can see even though the outcome prediction overall survival is the only difference between the IO treatment group, but it's also better than the second line systemic chemotherapy. So I think for the second line, I do not check the PD-L1 test for second line, but for the front line, I will do this kind of a testing for front
How
line.
about Professor Kondo? Is the second line
I'm not sure.
not required?
I'm not sure, but according to the Keynote 045, actually there is no difference between a patient with or without a PD-L1 expression. Actually, those are the results. Yeah, this one, yes. Could you back to the before? Yeah, previous one. Yeah. No, that next one. Yes, this one shows looking at comparing the overall survival and objective response rate between the patient with or without PD-L1 expression. Actually, there's no difference in overall objective response rate and overall survival. So maybe in a sequential therapy setting, I think the PD-L1 expression is not so important compared to the first line. Yeah.
Yeah, in my opinion, I also think, because even the CPS less than 10 still have a good response. And if the patient receives the second line, it means it failed after the chemotherapy and no other treatment available. So I don't think the PD-L1 is very important for the second line. Yeah. And your slide?
This is my slide actually. There's a lot of many RCT. This is the RCC study, and looking at overall survival, the progression-free survival, the survival, and among the patient with or without PD-L1, and looking at those studies. This is the most of the first-line therapy, but objective response rate is likely to be higher in patients with showing the positive L1. So in the RCC, especially in the first-line setting, probably PD-L1 is also a good marker for selected patient in RCC.
Even
as well.
first line and second line?
I'm not sure. Looking at the nivolumab as a 0 to 5, actually there's no difference between the patient with or without PD-L1. So maybe in RCC situation, and PD-L1 is not so important, less important in the second line than that in the first line therapy. So this is the current issue of the PD-L1 expression is antibodies are different in each trial, and also the evaluated cells are also different in each trial. So those need to be standardized, And also the factors should be considered is including such line is used as we discussed, and also according to the neoplasm, I think the difference positivity and one is positivity is different. So those factors should be considered. But I think the PD-L1 is also a possible biomarker in the UC.
And there are some papers said the PD-1 is not related to the OR, but some people say yes. So some controversy for the UC. So you can also see if the IC2 or 3, there's no difference. It means for the second line, the PD-1 expression, I think, maybe so important. Yeah, you can also see if the CPS less than 10, still a lot of patients can benefit from the IO treatment. This is the same second line. Yeah, even the PD-1 less than 1%, there are still some patients can benefit from the IO treatment. Okay, and last year, FDA alert, you should be very careful to use for the PD-L1 negative patient for the first line treatment. So, do you agree test the PD-L1 for first line treatment in cisplatin ineligible?
Definitely, I agree with you. Yep.
Of course, I agree. I agree with the required testing the PD-L1 in first line. Yeah.
So I think everyone, if the IO will use at the first line, PD-L1 status is very important. But for second line, it depends. Yeah. So everyone agree to test. Yeah.
This is my slide. I think the cisplatin ineligible is especially for the PDA, especially for the IO for frontline for the first line. You can see the PD-L1 positive. You can use the immunotherapy for this kind of a patient. But if you test the PD-L1 is negative, I think maybe systemic carboplatin may be beneficial for this kind of patient. I think this algorithm for this in the coming years. Also, you can see the Keynote 661 and the EBGO 130, and PD-L1 testing is now integrated into the decision making for the first line treatment of the cisplatin ineligible patient. Of course, you can see the bar. FDA and the EMA won't decrease the overall survival. It decreases survival with the first line atezo or pembro in cisplatin ineligible patient with a lower PD-L1 testing. So we should check this kind of testing. And I think the biomarkers in this kind of first line setting will be a predictor for this kind of efficacy. Yeah. And maybe the biomarker become incurable in the treatment tissue because PD-L1 always is a dynamic. So I think the biomarker for second line for the metastatic for the subsequent treatment choice might be a dynamic, and maybe for the after treated tissue maybe is a biomarker. Yeah.
Okay, so this is the PD-1 first line, but in this study, the overall survival is not related to the PD-1 analysis. But I also have a question about the atezo, because they only stain the immune cell. So maybe there are a lot of their studies show the PD-L1 is not related to the response. Yeah, maybe this is the problem. Okay, so even the first line, CPS less than 10, still OR 23%. So I think the PD-1 maybe serve as a predictive marker, but maybe some patients, if they have low PD-L1 expression, still can benefit from the IO treatment. We must keep in mind. Okay, and how about the pseudo progression or hyperprogression? Is that reality or is only a myth, Professor Kondo?
I'm sure there is pseudo progression or hyperprogression after the immune checkpoint inhibitors. Yes, we have several patients. Yeah.
Professor Yang.
My point of view is pseudoprogression or hyperprogression might be perhaps is a miss because every kind of phase 2 or phase 3, even though the first line or second line studies for this kind of MUC, you use the image RECIST criteria to definition for the progression, but they still get the better result, efficacy result from the first line or from the later line. But from the RCC or any kind of prostate cancer, we can use this kind of pseudoprogression or hyperprogression to maintain this kind of treatment if we don't have other treatment choice after this kind of treatment. But if if we do have a kind of such as a FGFR inhibitor to be later line after the IO treatment failure, I think the definition of progression is very important to proceed this kind of a subsequent treatment.
Okay, so Professor Yang said this is a myth, and Professor Kondo and I said this is the reality. So Professor Kondo, can you explain?
Actually, this is not my slide. So
I think this is my slide. This is my slide. Because I think the FGFR inhibitor maybe as a later line treatment after even though the subsequent chemotherapy or even though after the IO therapy. I think the FGFR response, even though for the later line or fourth line, you can see the response is still more than 20%. So we need to identify the true progression rather than the pseudo progression to maintain IO.
But yeah, if we're looking at the clinical trial from the several studies, there the first part just after the initiation phase, the survival curve of the immunotherapy is just below the conventional therapy. So I think what we need to see what happened. Could you go on this next slide? This is a patient. Is it a RCC patient who had metastasis to the TH6? And the TH6 metastasis developed during the third line TKI therapies. Could you go forward? So then we started nivolumab for this patient, but 4 days after the initiation of the therapy, the patient was sent to ER, and MRI showed acute progression of the TH metastasis and just compressed spinal cord, and she showed the paraplegia. And we underwent the decompression surgery, but we could not improve his paraplegia. And also, this is a second patient. He started nivolumab, and 4 days after the initiation, he was sent to the ER with a consciousness loss, and a CT showed the multiple metastasis with hemorrhage. And actually, he died 7 days after the initiation. So I think those things, if we can see that those patients, I think the immediate progression exists, I think. Could you go forward? And also, brain mets should be the screened. And I think that we need to screen the CNS mets before starting the IO. This is, I think, the most important thing. And actually, we recently published the data to the targeted oncology and looking at immune progressive disease. And we have 17 patients showing the immune progressive disease. And the PFS and overall survival is very different, so totally different. And the predictive factor is female and poor risk and shorter prior time to progression. Those are the factors for predicting the immediate progression. So I think it's there is immediate progression. So we should be very careful. So this is there is a pseudo progression. What is the difference between the immediate progression and pseudo progression? I think the onset of the time is different, and for the immediate progression, its onset of the time is within within month and always symptomatic, and patient need to be hospitalized. So, but it's very difficult to distinguish each other. So the summary of the immediate progression is fine 10 to 20%. Those are the risk factors, and we need to screen the CNS mets. But after CNS is treated with local therapy like a gamma knife, I think we need to start nivolumab therapy for this patient.
Okay, I think that little Dr. Chang have mentioned this morning. I will skip this. There are some papers talking about the hyperprogression, and according to the definition of the hyperprogression, if from the RECIST criteria, if the tumor growth rate 2 times, it means the hyperprogression. So in the real world, it really happened. So this morning, I think little Dr. Chang had mentioned this. Yeah, my daughter. Yeah. Okay. Since time is limited, so we switch to the question 9. How regimen do you think can define the IO efficacy?
Actually, this is a very difficult question to answer, but I think it should be, we are expecting the more, effectiveness with a combination with IO plus something, right? Something.
This question, I think all combination will have immunomodulation effect to get the better anti-tumor response, because you can see the pre-treatment doses, you can see the PD-L1 and the CTLA-4 after those doses, you can see the increase circulating tumor cell and more. So if we can trying to enhance the dendritic cell and release the cytokine to change the tumor microenvironment, maybe we can get the better PD-L1 efficacy result and following by before, and you can see the combination from the anti-PD-1 and plus CTLA-4. They can plus CTLA-4, they can enhance the dendritic cell to release the cytokine and to change the tumor microenvironment to get a better objective response from this kind of combination. So I think even though the radiation, they can get the immune modulation to get this kind of better anti-tumor response.
Okay, so now the radiologists are very interested in the immunotherapy, because they say they will change the game in immunotherapy. They will make the cold tumor to become the hot tumor. So maybe in the future we will invite the radiologists to come to participate our meeting. Yeah. And how about the sequencing? Professor Kondo.
Yeah, I think this is another difficult question to answer. But if you're looking at RCT of the combination therapy, the PFS is only a 13 or 14 months, which is a little, few months longer than a single agent. If we combine the two things, I think we're expecting longer and longer progression-free survival. But it's not so it's shorter than we expected. So maybe better sequential therapy may be better, but it's very difficult to answer currently. So we need to have the results of the RCT.
Okay, since time is limited, yeah, you can refer to the paper published in the EU last year, and the sequencing is much better for IO than chemo, than IO. Yeah. Okay. So the role of IO for TX ending or MIBC or CIS, and Professor Yang.
I think the bladder cancer is very difficult to treat, especially for even though the lung muscle invasive bladder cancer, because you cannot get the better response, especially for the complete response, even though the adequate TURBT or even though combined with BCG installation. But I think the Keynote 057, they can get a better response for this kind of lung muscle invasive bladder cancer. You can see even though the TURBT with intravesical BCG therapy, you can get 30% experience recurrence within 1 year, and 40% with progress to muscle invasive disease. You can get this kind of, even though we can more than 20% they progress to metastatic disease. And if we get the adequate BCG therapy, at least 5 or 6 installation or induction of BCG and 2 or 3 dose of a maintenance therapy, and they still refractory or relapsing, maybe we will offer for this kind of a radical cystectomy for standard treatment in nowadays guideline becoming us. But maybe moving forward, and if we can not to do this kind of radical cystectomy in the earlier stage, do we have any kind of novel therapy to reduce the risk of recurrence and preserve the bladder? And you can see the pembro. Maybe we can move forward because of the time limit. You Keynote 057, you can single arm open label phase 2 study. They can get this kind of a single arm for this kind of a CIS with T1 or any kind of a papillary disease. They can use pembro 200 milligram, and this kind of a treatment, they can still have a persistent disease or recurrent disease. Okay, we can move forward to this kind of the result. We can get a better complete response, especially for about almost 40%, but still have 45% with persistent disease, but long of progression disease to T2. Or HRV score just HRV score disease just 1%, so we can get a better complete response, and also we can get a better time to the duration of response, more than 6 months is more than over than 80%. They can get this kind of longer duration of response, and also 70%, more than 70% have ongoing response, and time to complete response is about in 3 months. One patient, one patient they get the complete response still undergoing the cystectomy. Only one patient, but more than 80% have a complete response duration. More than 80% they can get more than 6 months, and about the AE, about the immune treatment-related AE is not so higher than comparing with other first-line or second-line treatment. But comparing with radical cystectomy, maybe it's a less adverse event than this kind of medical treatment for non-muscle invasive bladder cancer. Still have a neoadjuvant treatment option in, especially for
I
muscle
think we
invasive.
can skip this because I will talk about this in the afternoon. Okay. Okay. Last question. How about how to manage the IRA, Professor Kondo?
Yes, this is from the results from the RCT for the RCC patient. Actually, it's very difficult to define what is the IRAE. So only one study shows the real instance of IRAE, which is a combination of avelumab and axitinib, and shows that 38% of the patients showed any grade of IRAE, and 11% of the patients need to have high-dose steroid therapy. So IRA should be, can be found in many patients. And actually, this is the real-world data from 70 patients who treated with nivolumab for RCC, and 49 patients showed any grade of IRA, and most of them rash. But the severe, including the severe things, it's ILD and colitis and diabetes, and those can be found. And there's no IRA and predicting factors for IRA so far, but several factors are reported, and some IL-17 or a neutrophil activation marker or something like that, but it's not routinely examined in a clinical practice. And actually, those are the how to treat the IRA recommended from the ASCO guideline. So grade 1, grade 2, grade 3. But I think we would discontinue the IO therapy for grade 2 or more pneumonitis or grade 3 colitis. I think we should not re-challenge